Well, I'd like to tell you a story about how some information that some doctoral students have generated over the years has provided some good analytical information that has allowed some good public policy to be adopted by government. I warn you, this won't work if you have an ideological government, but it does work when you have governments that are happy to take this sort of information on board. As background, I'm going to tell you why STI centres exist, not to protect my job, but just because it's important for you to understand the context that follows. I'm going to tell you why sex workers are critical to the control of sexually transmitted diseases or not, depending on what your public policy has in place. And I'm going to tell you a bit about what good public policy is for sex work. So this is a very important equation, and it drives my everyday. So it's the basic reproductive rate, and it's the thing that tells what the prevalence of a sexually transmitted disease will be in a society. And there are only three things that determine it. If you like, there's three knobs you can turn that will determine what the prevalence of infection will be. It's the probability of transmission, it's the rate of partner change, and it's the duration of infection. Now, so if you made condoms more available, like having vending machines, STI rates would go down. If you're able to control the rate of partner change, and no one has been able to successfully do that at this point in time, you'd bring the prevalence of sexually transmitted infection down. But most importantly, if you could do something about the duration of a sexually transmitted infection in the community, and that's where most of the money is, you can make huge differences. It's why, for example, the prevalence of gonorrhea in heterosexuals in the US is about 10 or 20-fold higher than it is in Melbourne or Sydney. And I use this as an explanation. This is my favourite place on planet Earth, on the left-hand side here. It looks down to Cape Otway at Apollo Bay. And if you can imagine that the basic reproductive rate is like throwing a match onto the ground, the things that determine whether a bushfire will take off are things like the fuel load, the fuel moisture, the wind speed, the ambient temperature, the relative humidity. It's exactly the same for a sexually transmitted infection. If you fill that A380 with people with a new sexually transmitted infection and you land it in Melbourne, if the basic reproductive rate for that infection is less than 1, you don't have to do anything. You can just relax, go home, have a cup of tea, watch a DVD, whatever you like. It will fade away. On the other hand, if the reproductive rate is more than 1, you'll get an epidemic occurring, as did occur with HIV, for example. And here's an example of something you can do to control the D. So this is syphilis over the last 100 years or so in the UK. You can see what happened. World War came along, all the young men were recruited, none of them wanted to die as virgins, so they ran out and found sex workers. You got a huge increase in the prevalence of infection, but the thing that made the big difference, the thing that saw, look at the women there, virtually go to zero, reproductive rate turned to zero, was penicillin. And no matter what happened, Woodstock, the Cultural Revolution, all sorts of different things, nothing could get it up again. It was down forever. And that is the key to the control of sexually transmitted infections, what you can do to the basic reproductive rate. Now, the really important thing and why it matters to you is that if you can get the reproductive rate down, it costs a lot less. So this is an example of gonorrhea, and what we've done is we've got a prevalence of gonorrhea in the dark line, and then a dotted line is the services. If you turn the health services up, so that man who gets a urethral discharge can get it treated within 24 hours, and that is the median duration of symptoms of men with gonorrhea at our centre is 24 hours. They haven't got time to pass it on to anyone, so it'll fade away. In contrast, if you've got a society where they can't get treatment, they haven't got anywhere to go, it costs too much money, it's too far to go, you'll get endemic gonorrhea. And you can see that if you push it to 20%, all of a sudden the reproductive rates fall into less than 1 and gradually it'll decline. Now you can put more health services on, 30% or 50%, it'll come down more quickly. But the key is, if you look at that dotted line, it's much lower at the end than it is at the beginning. So much less health services to keep it down are needed at the end than are needed in the beginning. There's some good examples of public health policy of the rate to the reproductive rate. Gough Whitlam introduced Medicare, suddenly healthcare was much more accessible, reproductive rate for gonorrhea went down, and gradually the disease declined. And of course needle exchange programs for HIV are well known with Neil Blewett. And so with sex work we have the same thing. We can put good public policy in place. Because of this is the early 1990s, the HIV epidemic is coming along. The Victorian government at the time had a choice. It could try and prohibit sex work. I have to tell you that never ever works. Sex and appetite are the same sort of things, is why obesity and sexually transmitted infections are so difficult to control, the biological urge. But it didn't choose a abolitionist approach on the left-hand side. It chose to regulate it. So it regulated sex work and brought STI rates down. I'll show you in a minute. The graph on the left here, the picture on the left, is Kalgoorlie, where sex work still remains illegal. And on the right is one of the brothels in Melbourne. And this is an example of why sex work is so important to get under control. This is sex workers in 1981 in Africa and 1986. Prevalence of HIV has gone from less than 5% up to about 70%. Then it spreads to men with sexually transmitted diseases and lastly to antenatal women. So it's very important to get these sort of things under control. So in the 1990s, and good on them, because making sex work legal is quite a difficult thing for governments to have done. They regulated, and they said what we're going to do is we're going to have legal brothels. We're going to require the individuals working in those brothels to have monthly swabs and 3 monthly blood tests. You can work in a brothel or the private escort agency, and there's a whole list of occupational health and safety things to protect the sex workers. But the outcome is that the community is therefore protected. So, for example, sufficient light to allow, I don't like the word prostitute, but it's the word that's used in the legislation, to check for signs of a sexually transmitted disease, must provide free condoms and lubes and use by dates. It goes on and on and on. And so if you look inside a brothel, and here's some pictures for you, you'll see the light. So all rooms in all brothels have, because the legislation says you've got to do it, sufficient light so you can tell if the client has a sexually transmitted infection or not. And again, here's another room with another light. But time's passed on. HIV hasn't been passed on from sex workers to the public, and STI rates in sex workers are extremely low. So it's been incredibly effective legislation. And just to give you an example of how effective the legislation is, this is some work from one of the students at our centre. The black line is the incidence of chlamydia in the community, runs about sort of 4%. The red bar is the line of the incidence of chlamydia in sex workers coming to the centre, so a lot lower, with private partners, and the yellow bar is sex workers without private partners. So the effective thing is, first of all, sex workers have very low rate or very low incidence of chlamydia, but it all comes from private partners. It's got nothing to do with the clients. It all comes from their own private partners. And if you look at it at a community level and say, we'll do a case control study of chlamydia and work out what are the risk factors for chlamydia, well, it'll be no surprise to you that having a new sexual partner in the last 3 months is a risk factor for chlamydia, or contact with someone is a risk factor for chlamydia. But at a population level, once adjusted for the number of sexual partners, antibiotics in the last 3 months reduce your risk of chlamydia. Condoms surprisingly reduce the risk of chlamydia. But look, sex with a sex worker reduces your risk of chlamydia, and the effect of that is more powerful than anything else. Remember, that's not to say you're at zero risk, but if you have sex with a sex worker, you're at lower risk than you have sex with anyone else in the community. So very effective legislation. But we have a new problem. STI rates are rising dramatically in heterosexuals, but particularly in men who have sex with men. These are the rates of gonorrhea, and the line on the left, the green line in men, has doubled in the last 18 months or so. So we're really hitting an absolutely new era where we're going back to the 1970s before HIV appeared. Same sort of things are happening with syphilis, and that again has doubled in the last 18 months or so in men. So very, very high rates of sexually transmitted infections. When I first got this job in 2001, we saw 2 or 3 cases of syphilis in a year in the centre, and now we see 500 cases of syphilis in a year. So that's not a very good report card for STI control on my behalf. And this is an example of what this centre looks like on a typical busy day. So all the people in red on the right-hand side have been waiting an hour. All the people in yellow have been waiting more than half an hour, and the people in green have been waiting for less than half an hour. It's about 1 o'clock, 24 people haven't been seen yet. So we've got to do something to unblock this clinic. because some of those people in red are going to have a urethral discharge and some of them are going to walk out of the centre and not get treated. And we said, well, who's using up all our resources at the centre? What is the effect of this legislation that says that these sex workers have to come in every single month and have tests for sexually transmitted infections? Well, the yellow is the light colour is the percentage of consultations at the service used by either sex workers, men who have sex with men, or all clients. And the dark colour is the rate of STIs diagnosed in those particular groups. And you'll see that sex workers are taking up more than 15% of our consultations but contribute virtually no STIs. In contrast, gay men take up only 12% of the consultations in the clinic but contribute 40% of the consultations. So the problem is you can't really get rid of the sex workers, because if they can't get their tests done, they can't get their certificate, they'll move outside of the legal industry into the illegal industry, which is a far more dangerous place. So we're left with this issue of rising rates of sexually transmitted diseases, particularly in gay men, very low rates in sex workers, and the fact that sex workers are clogging our STI service and pushing up the reproductive rate for infection in the community as a whole, which will increase STI rates as time goes by. And some modelling was also done to show that it costs $90,000 to prevent every case of chlamydia by screening sex workers, $4 million for every HIV infection, or $10 million for every quality adjusted life year. And that doesn't compare very well to the sort of price ceiling, which is about $50,000 per quality adjusted life year. So we needed to provide lots of information to the government to convince them to say we shouldn't screen people monthly, we should go perhaps to 3 monthly. Again, a difficult decision for governments to have. There's some very right-wing members in the government at the time. So we gave them the research that showed STI rates are very low. There's no transmission through sex work. It's all through private partners, and it's much less than the general community. It's very cost effective to make a change from monthly to 3 monthly. Effectively, we would create 3,000 to 4,000 consultations like that, because they wouldn't have to come in monthly. We'd create more access for people at higher risk, and it's also extremely expensive. So there we go. We changed the legislation. We were delighted. The 7th of October, I remember, the clinic changed overnight. It was an amazing change. So we went from monthly screening to 3 monthly screening and dramatically increased the access to the clinic for people at high risk of STIs without spending a dollar. And so what's happened is the light colour is the monthly screening, the dark colour is the 3 monthly screening before and after the 7th of October 2012. We see more women who are not sex workers, more heterosexual men, particularly more gay men and less sex workers. So it's not a surprise that has happened. But more importantly, because symptoms are strongly predictive of the prevalence of a sexually transmitted infection, more good is done by treating an infected person than an uninfected person. We've seen the proportion of consultations in symptomatic women go up, in heterosexual men, in men of sex with men, and in the total clinic as a whole, and go down. So symptomatic sex workers make up a much smaller contribution now. And there's a surveillance system in place now for sex workers. This is the number of sex workers we see every quarter, the number of individual sex workers we'd see in a quarter. They're all tested for chlamydia, gonorrhea, syphilis and HIV. There have been no cases of HIV, a couple of cases of syphilis only, no change as a result of moving from monthly to 3 monthly screening. It's important that this information is available to the government, because there's some very powerful lobbies in the sex work area. There's these people called abolitionists who want to completely abolish sex work. So just to sum up in time for your afternoon tea, it's been a wonderful privilege to work at this particular centre. We've got a large centre with a wonderful database and data systems that's allowed these students to pour out this information to the government so they can base their public health policy and decisions on analytical data rather than on ideology. And if I can just finish and thank John McNeil. He gave me some wonderful advice about 20 years ago. He said, "Kit, set up a good database at the beginning, you'll be set for life. Well, he gave some very good advice, so thanks very much.